So this is the first case, a 68-year-old lady with 10 years duration of symptoms, and these are her x-rays. So I'll just stick to the one side. I'll start from Dr. Kiran. Yeah. So quick comment, sir. Anything special or?
It's a 68-year-old lady, so I would like to assess the integrity of the medial collateral ligament. So have you got any stress x-rays?
No stress x-rays. This is what we have.
Well, this is most of the standard sort of patient scenario in our practice, and I think you have to apply all the basic principles of good joint replacement. You got to get your soft tissue releases optimized, and I think just have to look at that cystic area on the medial side and be prepared to augment that using her own bone or metal, depending on the cost. I prefer to be more biologic in my approach to reconstruction, and be prepared to keep a constraint on the table.
So Dr. Milind, any special tips to deal with this case?
The same thing, worried about that bad patch on the medial tibial condyle.
Condyle, okay. So you're worried about the bone defect. What about the subluxation? So do you think the subluxation will be a problem or?
Once we align it, minimal bone cuts.
Yeah, so why minimal bone cuts?
So because of the excess laxity.
Right. So what about the medial sleeve release? Do you anticipate too much of a sleeve release or not much of a sleeve release?
No, not much.
Why is that? Why do you think the sleeve release will be lesser?
Because I'm sure I'll get it aligned.
Yeah. So the point here to be noted is that the distance between the medial epicondyle and the tibia has shifted laterally. So the MCL also is stretched out to an extent. So you don't need to probably release too much. There is a medial condyle fracture there. So sometimes if you try and release it, you may end up inadvertently releasing the superficial MCL. So Dr. Hemant has a point to make.
Just one point. Typically when you have a sublux knee like this, you have to release popliteus at times.
So I was coming to that with Dr. Saraf. So the popliteus muscle is shortened because of the lateral subluxation. So you may have to do a pie crusting of the popliteus to align. So Dr. Saraf, what implant will you choose for this patient?
Regular total knee replacement primary implant, they are more than enough for this. There is, as Dr. Milind Kulkarni rightly said, that we have to take minimal tibial cut.
How much and minimal? By minimal you mean?
Minimal means 4 to 5 millimeter, not more than
5
that.
millimeters.
Second thing is there is a small fragment attached to the medial collateral ligament which we can see in this X-ray. So we have to always take care to remove that fragment, and if you keep some bone attached to it, it's also okay. You can keep it like that. On the tibial side, we can downsize the tibia if there is defect on the medial condyle, and that's all I think we can.
Mahesh, cruciate retaining or a PS?
Yeah, and also one more question probably to Rishikesh. Now since you have got a new robot as well, do you think that by doing a kinematic alignment on this knee, you will avoid any releases? Because that is what kinematic alignment is. That you put the implant where the bone should be, and you got robotics, so you can put it perfectly where the cylindrical axis of the femur is, so that you don't have to bother about the releases. You leave it in about 3 degrees of varus on the tibial side, leave it a little bit more valgus on the femoral side. You get perfect anatomy with your robot. So would you accept that, to put it in kinematic place?
See, Mahesh, actually I was listening about all these debates since yesterday against the technology. The important thing we have to always remember.
I'm saying that you have
It is may be against or may not be against, but the thing is, surgeon has to decide preoperative planning, and he has to follow the planning. Robo is going to help you to execute what you have planned. So if in this case, whatever release is required or whatever alignment we have to do, that is preoperative planning of the surgeon, and robo is going to, or navigation is going to help you to exactly execute your planning. So that difference, if you understand, then you will not have all these questions in your mind.
Quickly, I think we'll stop here. So, the argument on technology keeps going on and on. Can you quickly tell us whether you'll do a cruciate retaining or a PS knee in this case?
Yeah, we can go ahead with cruciate retaining knee in this case also.
Okay. What about you, Dr. Milind?
PS.
PS, yeah. Kiran?
PS.
Yeah. So fair enough. I think each one has his view, and this is the walking video fat patient, and so this is a CAS cruciate retaining knee replacement. So I think there's nothing much to talk about. Any comments on that? I think it looks okay.
Looks well aligned.
Yeah. Okay. So now we have more severe deformity. This what I called as located varus. I think we'll start from Dr. Saraf. So can you quickly?
Yeah, this is most probably a case of fixed varus, and if on stress views, you will not be able to open this kind of the varus.
So do you guys routinely get stress X-rays in these patients?
Yeah, we usually try to get stress
Right,
X-rays in all these patients.
Right.
And second thing, on tibial side, you can see that there is complete loss of the medial condyle.
Yeah.
The tibia is subluxated, so LCL is again raised. So in this case, you have to take again minimal cuts, 45 millimeter, maybe that 4 millimeter will be also more in this case. So you have to just take out the cartilage from the lateral condyle, and you have to reconstruct the medial tibial condyle. Either you can use a bone graft and screws, or you can use a wedge in this case. Second most important thing is, in such cases where there is a complete loss of the medial condyle of the tibia, always use rod in such cases. That will give additional stability. And that's all. On
Dr.
femoral side, I think.
Milind,
it's okay.
any special tips to your tibial cut? Where will you put your extramedullary guide? Let us assume we don't have a CAS or a robot here.
Yeah, I don't use CAS.
So you use a conventional device. So where will you put your extramedullary guide? Will you put it where you normally put, or will you make any changes to the tibial cut?
No, normally I'll do.
Normal. Any difference of opinion, Kiran?
Well, again, here in my mind, I'll keep all the armamentarium ready on the table.
No. Regarding
but, for the tibial positioning guide,
Yeah.
I'll use the landmarks, the conventional ones
Standard.
like the tibialis anterior tendon, the tibial tuberosity. I'll factor the bowing of the tibia as well in this particular case.
So the use of conventional extramedullary alignment guide is based on the premise that the anatomic and mechanical axis of the tibia are the same. But we have observed that some of these severely bowed cases, it's a good idea to get a long leg film of the tibia.
I was going to ask you that. Have you
Yeah,
got any
and
more
then
images?
measure the mechanical axis of the tibia. Sometimes the extramedullary guide rod has to be shifted more laterally, so that the cut is now neutral. Otherwise, you end up with a varus cut, and there is evidence on that. Okay. So, any role of tibial? Dr. Parag is here. The X-rays disappeared, I think. It's okay. Yeah, X-rays come back. Any role of Dr. Parag? Any role of tibial reduction osteotomy or medial pike crusting, MCL pike crusting? What would you tell the audience? What?
Yeah, so both the points are very important. As far as I can see, both will be required. So you have to lateralize the tibial component so that, and do the reduction osteotomy. I find that a very useful step, and in this case, I would not hesitate to do it. You know, you go slightly one size less and then lateralize it and then remove that. That helps to balance the knee. And pie crusting is something which I like, and I've learned it from Hemant. Hemant always talks about it, though there are some people who talk against it too. But the only thing is you have to do it carefully, not too many, nicks. Don't puncture it too many times. I would say 8 or 9 times. I use a 11 gauge knife or a 16 needle.
Choice of implant?
Both the things.
Choice of implant? Dr. Saraf? So you said
PS.
CR in the previous one, now you're saying PS. Why?
Yeah, because
would-
this is a fixed varus, and most of the time, once you correct all these things, you cannot
It's very difficult to
preserve
balance the
posterior
PCL.
cruciate ligament.
Right.
So then, in this case, definitely the PS implant, and with rod and wedge.
Dr.
or
Milind,
bone
any
grafting.
thoughts on the use of anterior stabilized insert? Have you any experience on that?
No.
No experience. Okay. Kiran would agree with that.
Yeah, PS, stem, and
Yeah.
think about the popliteus tendon here.
Yeah, so that I think I'll just quickly go through. So we've lateralized the tibia, we've done a bone graft, stem extension, and used I think it's a ultra congruent insert, so it's anterior stabilized. So the PCL probably needs to be sacrificed. With CAS, I'm worried about the pin track fracture, so I don't usually cut a box. I have not cut a box in 10 years. No box cuts. It will have a ultra congruent insert, and patients have done reasonably well. So
Krishna, one question about the stem.
yeah.
Can you explain what is your philosophy of a stem, a short, stubby,
Yes,
fully
sir.
cemented, or snug fitting ones, or in this case, what was the
So
rationale for
the
this.
challenge with these sort of lateralizing the tibia is you need to use an offset stem if you want to put the stem in the center of the canal. I have in the past gotten away without the use of stems as well. So in this case, for me, it's just a dangle stem, as Dr. Anavat puts it. You just take a little bit of load off the proximal tibia. I don't cement the stem. It will only proximal third of the stem which is cemented, and you can't lateralize the thing and then put a central stem at the same point. So either you reconstruct it to the pre-existing level so that you have a central stem, or you choose to lateralize it. So you can't have the cake and eat it. So I think I'm happy with this. The patient is pretty okay and doesn't make any difference. I think we'll, this is the last case, or should I do the
we can
extra
do the
articular
last
one?
Or should the last one, extra category.
Okay, yeah, okay. So this is a case of previous osteotomy for the distal femur when the patient was probably 12, 13 years of age. So quickly, Dr. Parag, any special tics on this? The patient is 62-year-old.
So whenever we have an extra-articular deformity, this is my indication for doing long leg X-rays.
Yeah.
At other times, I would not. And the very fact that when you do a short film, that should raise that thought that there could be something more, and then you go for a long film, which you have done. So that is critical. And these are one of the few cases. Even though I have a cast machine, I've stopped doing it. But this probably a cast would be beneficial in this case. The problem comes that if you are not doing cast regularly and you do it for one odd case, this is the problem.
Difficult one, yeah.
But then this is the distal femoral cut is going to be quite challenging. So you have to decide now whether you want to do an osteotomy first.
Yeah. So
And
how do you decide that? For the
so
audience sake, yeah.
Yeah. So I would definitely draw the lines and see where the mechanical axis is going and whether it's transecting the medial epicondyle and the axis below the tibia. And in this case, I would have to do an osteotomy. So the question is whether to do it osteotomy with the totally or one stage osteotomy and second stage TKR.
Dr. Kiran, any particular guidelines to the audience to the degree of femoral deformity and the distance from the joint, which will determine when you will choose to do an osteotomy or when you will accept it?
Yeah, if you permit me, I have to ask you, are the hips okay in this patient?
Yeah, hips are okay. Absolutely fine.
Yeah.
You have to trust me on that. That thing got cut when I was doing the editing. I'm sorry for that.
Yeah, I mean, the principle is if the intra-articular correction will compromise my collateral ligament, I'll be very, very cautious about that.
Yeah.
And certainly in such deformity where the canal is quite offset, to get an intramedullary rod in will be a huge challenge, and you have to be prepared to use CAS or call someone who is an expert in it and get you, a safe pair of hands next to you.
So any value to the angle of the deformity on the femur?
It's a torsional deformity, so it's very difficult, but I would again use the overall mechanical sort of alignment.
So you mean to say that you'll draw the mechanical axis of the femur, and if you draw your perpendicular femoral cut and the lateral side is violating the lateral collateral ligament, that is when you would probably look at a simultaneous osteotomy with TKR.
Yeah,
so very valid point.
I won't commit to that. I will see and then decide.
So the both points are very valid. Dr. Parag makes the point, you must do a long leg film and do the mechanical axis of the femur and draw the angle. And in general, 20 degrees or more of deformity of the femur closer to the joint will have a greater impact on the joint. So if you had the same deformity in the subtrochanteric level, the effect would be only 1/5 of that deformity. So you have to divide the femur into 5 segments, and whatever is the distance from the center of the hip to the center of the knee, farther away the deformity, lesser will be its impact on the joint. So if you had a 20-degree deformity at 1/5 of the distance, the impact would be only 8 degrees, which can be managed with an intra-articular correction. But this particular thing is difficult. Dr. Hemant, yeah.
Just one point on this scanogram. This is a cut paste scanogram.
Yeah.
And the rotation of the hips, rotation of the central X-ray and rotation of the bottom X-ray are different.
Yeah.
So this is actually a wrong impression. You need a one shoot giving you the correct rotation, because it almost shows the lateral view of the knee.
That's why I asked you.
The ankle is in
about
AP, the hip is in external rotation.
True.
and
That
it's
is
not
absolutely true. I think that point is well taken. Dr. Milind, any tips to...
That's what I was about to say. There is a rotational component which we have to...
So let us stick to the right
And
side.
if I
Then
can-
don't look at the
if
left
I
side.
can
Right side
correct-
looks reasonable. So we'll stick to the right side.
Yeah, right side. That if I could do it intra-articular in one stage, better.
So any tips on that, intra-articular, Dr. Saraf? You're using robotic or navigation, so...
Yeah, now, Mahesh, with robotic, this is definitely a simple case. It gives exactly idea about the how to take a femoral cut. Second thing, the problem what Kiran has already mentioned, that putting the intramedullary rod, which is not at all there required in robotics. So we can correct all this deformity. Only thing is, as you rightly said, that this deformity is very close to the joint. So most probably in this case, we require a osteotomy at supracondylar region, as said by Dr. Parag sir. And then if we do osteotomy, then we require additional rod inside the femoral canal. So these are the few things which are required. With that, we can definitely.
So for
correct this
any
deformity.
extra-articular deformity, the distance from the joint line, the amount of deformity on the femoral side, and second, do you anticipate any problems with the soft tissue balancing, Dr. Parag? For a femoral versus tibial deformity?
No, so definitely. So, if you see the distal, it is in varus plus the joint space is reduced. So, balancing the medial side is definitely tight and you are going to require it. The question is what approach you take. It will all depend on that, whether one stage and or two stage.
Right.
Or with
Fair enough.
osteotomy or all intra-articular.
So the point you need to understand is that distal femoral deformity will influence only the extension gap. The tibial deformity will influence extension and flexion gaps. So this is much more difficult to balance than a tibial deformity, because if you balance the extension gap, you will end up with a loose flexion gap. So you may have to do some difficult or not normal procedures to balance this. Dr. Vaidya, you had some point.
I think you had asked him, Dr. Saraf, whether you'll do it robotics. I think I will not do it with robotics at all, because intra-articular correction is not possible in this case. So I will definitely go for osteotomy correction and then plan it. I think still they have to they have not have a solution for such cases. Surely.
Yeah. So our take on these cases is, if the amount of varus required on the femur is 4 degrees or less, we would do an intra-articular correction with a permissible varus cut. So what I would do, I normally use a cast for this. I will do the tibial cut. I will measure my gaps and see if I am having to put the femur in 4 or 5 degrees of varus to balance the gaps. I would just do it intra-articular correction. It won't matter, because we have discussed that alignment doesn't matter, and that's what we did. We did a intra-articular permissible varus cut, converted a complex 2-stage procedure or this thing into a simple. Probably it will last 2 years lesser. I don't care, because I would then probably didn't do this procedure at that stage, and there is no guarantee that if you put a hinge or a long stem at that point in time, you can do it at a later date. So you bought some time using technology. I think Dr. Hemant also would agree that technology plays a role in certain cases. And the point which we need to take is, if you don't use it for the simple cases, you will not be able to use it for the difficult cases. I think we'll stop here. I thank the panelists for their expert comments. Thank you very much.
Thank you.
Thank the chairpersons, Mahesh, and all the faculty. Thank you very much.